Good afternoon, everyone. I'm Richard Griffiths, President-Emeritus of the Georgia First Amendment Foundation. I'm grabbing the microphone before we start to acknowledge something and someone very much worth celebrating. This afternoon marks the beginning of the 30th Bar Media and Judiciary Conference, 30 years. The first one was in 1989. It was conceived by some judges and journalists as a way to get real conversations going between journalists and judges and the lawyers that don't always see eye to eye. The goal was to help all three groups better understand the others, their needs, their motivations. Well, we've only skipped 2 years. The most recent was following 9/11. Guiding this effort for the last 28 years has been Peter Canfield. It is his labor of love, corralling the plenty of type A lawyers, judges, and journalists, getting them on a committee, getting them to work together towards a program that educates, informs, and challenges. We owe Peter Canfield a debt of gratitude. Thankfully, he's not going anywhere. But at this 30-year moment, we on the committee feel it's important to note his incredible contribution. This conference would not be here without him. Normally, I'd ask for a round of applause so Peter would feel good. Can't really do that on Zoom, but I can ask this. When you fill out your emailed review form after this conference, whether you like what the committee has pulled off or not, please add a one-line note thanking Peter for all he's done. We'll compile them and make sure he gets them. I also want to thank Georgia First Amendment Foundation President Kathy Brister and our back office team led by Lenora Kopkin, who've done a terrific job helping prepare for this conference, dealing with all the back office issues. They've done an amazing job. Now I want to introduce what I hope will be a suitably embarrassed Peter Canfield, who will in turn introduce the conference and the first panel of our 30th Bar, Media, and Judiciary Conference.
Thank you, Richard. I am suitably embarrassed. I don't deserve that. This conference has always been very much a group effort. Large planning group that's listed on the agenda. I won't name everybody. We have many newcomers each year, but also many like you and I who have been at this a long time. So before we get to the conference, I want to make a few quick additional thank yous. I'd like to thank two perennial people without whom this conference would not be possible, Ashley Stoller with the State Bar and Leslie Gaither of Kilpatrick Townsend, for all their work that they do putting this together. And last but not least, I want to thank, of course, our sponsors, our many sponsors who have stuck with us many years, including this virtual one. And with that, I would like to get the conference started. Welcome, everyone, and turn to Hank Klibanoff, who's also a regular, who helped organize this session and will be kicking it off for us now. Hank?
Thank you so much, Peter, Richard, and welcome to our audience and to our esteemed guests today. I want to tell you that the show will begin shortly. During the discussion, you will have questions. If you have questions, you may submit them through the Q&A on your Zoom. Chat, I'm told, is disabled in order to funnel all the questions into Q&A. So please do that. I am especially pleased today to be able to interview Andy Miller as the moderator, host of today's discussion. Andy has been a healthcare journalist for 29 years and is the CEO and the editor of Georgia Health News. From 1992 to mid-2009, and that's a period when I had the great pleasure of working with Andy in the AJC newsroom, he covered healthcare for the Atlanta Journal-Constitution. He won numerous awards and for reporting on hospitals, health insurers, state government, and Georgia's mental hospitals. He's been a member of the Association of Healthcare Journalists for 21 years and has served as the Atlanta chapter's president and he is a past board member of the Association of Healthcare Journalists. In November 2010, he launched Georgia Health News, a nonprofit health news organization, www.georgiahealthnews.com. Andy is married and lives in Atlanta with his wife, and it's an honor and a pleasure to introduce Andy Miller for the rest of the program. Thank you.
Well, thank you, Hank, and welcome to everybody. We have a excellent panel here to talk about COVID. I can't think of 5 people that could address these issues better than these 5. I'm going to introduce them first, and what I'll do is I'll ask each of them a couple of questions individually, and then we'll do some general panel questions. And you in the audience, if you have issues or questions beyond what we ask, we'd love to hear from you, as Hank said. We'll start introducing Dr. Carlos Del Rio. He is a distinguished professor of medicine in the Division of Infectious Diseases at Emory University School of Medicine, and he's professor of global health and epidemiology at the Rollins School of Public Health at Emory. He's also executive associate dean for Emory at Grady, and he does major work with the Emory Center for AIDS Research, the Emory CDC HIV Clinical Trials Unit, and the Emory Vaccine Treatment and Evaluation Unit. He's a leading infectious disease expert, not just in Georgia, but in the United States and the world. Dr. Patrice Harris is immediate past president of the American Medical Association, where she was the first African-American woman to hold that prestigious position. She's an Atlanta psychiatrist, and she has worked in the public health sector as well as a practicing physician. She spearheads the AMA's work on ending the opioid epidemic. She's a leading expert in children's mental health and childhood trauma. And she is a fellow of the American Psychiatric Association. She's also an adjunct professor at Emory and at Morehouse School of Medicine. Scott Steiner is president and CEO of Phoebe Putney Health System, which is based in Albany, which was a hot spot for COVID early on in this pandemic, not just in Georgia, but the country. Scott has been in healthcare administration since 1992. Prior to coming to Phoebe in 2019, he worked for the Tenet Healthcare Corporation and was CEO of 4 Tenet hospitals in Detroit, Michigan. Dr. James Curran is the Dean of the Rollins School of Public Health at Emory, and he is chairman of the Georgia Department of Public Health Board. He's a professor of epidemiology at Emory. And back in the early 1980s, Dr. Curran coordinated the task force on AIDS, which had emerged at that time. It was a pivotal time for AIDS research. And he was working at the CDC then, and he led the HIV/AIDS division there, and he attained the rank of Assistant Surgeon General while he was at the CDC. He is, besides being dean at the Rollins School, he's an adjunct professor of medicine and nursing and co-director of the Emory Center for AIDS Research. And last but not least, Amber Schmidtke is a public health microbiologist and a former CDC official who has done great work in terms of educating the public and people like myself on what's happening with COVID-19 here in Georgia and across the country. And she's the publisher of the Daily Digest, which is must-reading for people like myself and many other consumers here. So we'll start with Dr. Del Rio. This week, we passed a grim milestone, 500,000 Americans dying from COVID-19. How would you assess how the United States has performed in fighting this pandemic?
Well, Andy, first of all, thank you for the invitation to be on this panel. You know, I think that overall, this pandemic has been really an unprecedented event, really. We use that word probably too much, but it's probably the truth. Since 1918, the great influenza pandemic, we've never had a pandemic like this one. And we thought we were prepared as a country. We had all the plans, we had all the different things that we thought will get us ready. But once the rubber, meet the road, we were just not there. And unfortunately, the spread of this virus in our country has been very rapid because we haven't done a lot of the things that needed to be done. And I think the saddest part is, as you say, the number of people, that have died. 500,000 individuals, their loved ones, their family members, or people that honestly, each one of them is a tragic loss. And I would say that, none of us, a year ago, if you had asked me the question, how many people are going to die of this pandemic in the US, I would have probably predicted 60 to 100,000. I would have never guessed 500,000. And we're not done yet. And, the Institute for Healthcare Metrics and Evaluation in Seattle predicts that we're probably going to reach, 600,000 sometime in May or June. So when this is all said and done, we're going to have more people, or at least the same number of people die in this pandemic that in 1918 pandemic. Granted, we have more Americans, but we also have more technology. We have better health systems. We were supposed to be better prepared, but the mortality has still been incredibly high. So I would say that if we are going to do an evaluation of the response of the U.S., I would say we would not get flying colors. We have not done well. And I think part of what we need to do when this is all said and done is really revise and see where were the failures, what could be done better, and how can we avoid this from happening again. But it's not the right time to do it right now. Right now is the right time to try to end this, to vaccinate people, and to get out of this as fast as we possibly can.
What do you say have been the successes? We've talked about, the deaths and the impact, the negative impact, but what have been the successes that we've experienced? And also, what keeps you up at night? What makes you frightened about the future, if anything, about this disease?
Well, the successes have been not many, but one of the clear successes has been the success of science. And to think that we went from discovering a new virus in January to having a vaccine, and now 2 vaccines and probably 3 by the end of this week approved by the FDA for emergency use authorization. We now have over 60 million Americans and over 200 million people around the world vaccinated. That to me is an incredible success. So science did what it was supposed to do. It created vaccines, deployed it through clinical trials, and I think the investment in research paid off. So I think that I would say we need to be very proud of the research infrastructure in this country, because we got a vaccine in record time. And that's, that's something that, again, many of us would have said it was simply impossible to do. A lot of things keep me up at night. And what keeps me up at night now, lately, is to see, for one side, that we're doing better, but on the other side, that we are, looming problems ahead, like, for example, the emergence of variants, and the fact that people are saying, well, this is over, we're COVID fatigue, we're going to start going back to our normal, getting together, not wearing masks, et cetera, and we can get another peak. But what really keeps me up at night is to think that there's still 2 issues that we need to address. One is vaccine hesitancy. We still have a lot of people out there, probably 30%, 40% of people who are not sure they want to take this vaccine. And we need everybody as much as possible to be vaccinated. So vaccine hesitancy keeps me up. And the other thing that keeps me up is that we continue to see health inequalities in this pandemic. We saw health inequalities throughout the pandemic, and we're now seeing health inequalities in vaccine access and vaccine distribution. And if we continue that, we're only going to see further inequalities. A lot of jobs have been lost. A lot of pain has been had in this pandemic. And if you look at the data, most of the job loss and most of the economic pain has been in people who are, again, poor or Black and brown. So I also worry about the economic impact in populations and the potential social impact that can have in our country.
Thank you, Dr. Del Rio. Dr. Harris, I've got a couple of questions about the mental health impact, not just families who have been directly impacted by a family member, let's say, getting COVID, but also in the general public. As a psychiatrist, tell us about the mental health strain on America that this disease has caused.
Well, let me also add my thanks, Andy, for inviting me to this panel. I am a big fan of folks from different disciplines getting together. I recall days of meeting with members of the judiciary as a forensic psychiatrist in the Robucher Society. And so it's very important that we get together and have these conversations. You know, this COVID-19 pandemic has amplified a lot of fault lines in this country. You heard Carlos talk about the health inequities that are not new, but we are certainly now having what I believe is a more focused and serious conversation. Another issue that I'm sure Dr. Curran will mention is our many years of underfunding our public health infrastructure. And we've also ignored and underfunded our mental health infrastructure. And that is pre-pandemic. But certainly, again, this pandemic is elevating the conversation around mental health. And as you say, it is beyond the immediate grief, which is important, of those who have lost loved ones. But, you know, there's also grief around disruption. Everyone's life has been disrupted, no question. Some of us have had the privilege of weathering this storm through our homes and other privileges that many have not had. And so we are grieving. We have folks who are reporting increased symptoms of anxiety and depression, feelings of isolation and loneliness. As you mentioned, I chair the AMA's task force on the overdose epidemic, as we are calling it, because we've moved from opioids because it's much bigger than just opioids, but we have seen increased use of substances. We can't forget alcohol to cope, but also care has been disrupted for those who were already in services or were interested in achieving substances. And unfortunately, in the last couple of weeks, we've seen reports of increased suicides. Now, we have to be careful. We don't at this point want to draw cause and effect lines here, but clearly this pandemic is having a mental health impact on all of us. And as a child psychiatrist, you were going to ask me this question about what keeps me up at night. I am worried about the longer term mental health impacts because in this country, sometimes we have a short-term memory. In the midst of the problem, we are paying attention, and we have been paying attention and are paying attention to mental health, but that will need to be sustained because, as Dr. Del Rio said, we will get through the acute phase of this pandemic, but the chronic phase will include the impacts on our psychological health. And I worry that, well, I know we don't have the infrastructure, and I worry that we won't have the services needed to address those issues.
Another question, the statistics show us with COVID that there has been stark racial disparities in the number of cases and deaths, hospitalizations. What do you see as the reasons for that? And talk about the impact on communities of color.
No question that the issues around health inequities have been amplified, and where there is data, and let me start there, because unfortunately we have not always collected the data that we need to be able to even look at these issues in any intentional way. That's one of the many reasons the AMA and others, many on this call, have called for CDC and HHS and state and local public health departments to make sure they are collecting data by race and ethnicity and age and gender and zip code. But where we have data, I mean, just going down the line here, if you look at California, when you have Latinx community making up 39% of the population, but 45% of the hospitalizations and deaths. In North Carolina, 21 and 37. So where you have the data, there has been this disproportionate impact. And what are the reasons? And it's important that we say at the outset that it's not race. And actually, I hope that folks will have an opportunity to look at an article in JAMA about how JAMA, which is the Journal of the American Medical Association, editorial independence, I'm on the board, but different, is thinking through, as I think all peer-reviewed journalists and journals are looking at how we've been talking about race and ethnicity, But that aside, we know it's typically racism and not race, structural policies, practices, discriminatory policies that have led to where we are today. Because again, in addition to increased risks of hospitalization and death, we know that communities of color are more likely to be uninsured and more likely not to have a usual source of care, more likely to work in those service industries, right? Those frontline essential workers that didn't have the privilege of staying at home, more likely to live in housing situations, again, with multi-generational family members and maybe smaller housing arrangements where there was not the opportunity to go to a second bedroom or a third bedroom when you were experiencing symptoms. And also, again, not able to do the teleworking and more likely to need public transportation. And then again, on top of the pre-existing disproportionate burden of hypertension and diabetes, a lot of the issues that it made folks more vulnerable. So those are the many complicated reasons, nuanced reasons that we've seen these health inequities and disparities.
And vaccinations have lagged in communities of color as well. Is that an access to care issue? Is that a historical the legacy of historical discrimination, or a combination of both those factors, or others?
Well, I think it's as complicated as most of these answers are in public health answers are. Carlos talked about vaccine hesitancy. And as I talk about that, I want to make sure that we are, and there are many reasons that people may be hesitant to receive a vaccine, but I do want to make sure we carve out this sort of anti-vax community, because most Black and Brown community members are, and some would say, and I say, have some concern, legitimate concern, because of past issues such as the United States Public Health Service experiment at Tuskegee. By the way, I say that deliberately because we shorthand it to Tuskegee, but Tuskegee is a HBCU, and it really was the U.S. Public Health Service that was in charge of that study, the syphilis study. Henrietta Lacks, operating on enslaved women, members of the Latinx community without their consent, women. And so there are many reasons, but I think that that's all the more reason for us, and many have, and those on this call have sort of elevated and targeted our approach to those communities, and made sure that there was messengers and messages that folks in those communities trust. Because again, we have to be trustworthy. The medical establishment has not always been trustworthy. And I will also say that, it's important to think about and think through the distribution of vaccines. Now, I think the previous administration decided to, for the most part, administer vaccines or delivered to the states based on a per capita basis. And, I think as we continue to navigate through that, we need to be a little bit more targeted and perhaps dig into the details of the communities that are most hardest hit and make sure there's an equitable distribution. Sometimes people confuse equal and equitable. And I think we need to take that into consideration as we think through the next phase of vaccine distribution.
Thank you very much. Scott, you were at the center of the early outbreak here in Georgia, and Albany became a national story. Tell us what happened there, what led to this spread of disease there, and how Phoebe Putney and the community there reacted and responded to that.
Yeah, thanks, Andy. And again, thanks for having me today. What a great panel, and just privileged to be here with you all. We asked ourselves that many a times, why Albany? We're 40 miles off the interstate and off 75, and we sure, we saw what was going on in China, and it was in Italy, and then Seattle, Washington, and we were watching it like everyone else, and ordering extra supplies, and had our command center, and we thought we'd be sitting here in small urban rural Georgia watching watching this develop in the bigger cities. And actually, we are just 2 weeks out, or day 351, since we had confirmed our first COVID patient on March 10th. In reality, we had patients probably at least a week before that. It was actually on the 11th that one of our physicians was doing what they should do is in the ED, is listening to a patient. And as this patient whose condition was deteriorating, her ability to breathe, she was literally pointing around the emergency room saying, "That's my pastor, and that's my neighbor, and that's my cousin, and that's my aunt." And we began to really realize what was happening, not only the scope. We went from 0 patients to 50 in 3 days, to 85 to 130 in just 3 weeks. And for us, that represented almost 70% of all the patients in our hospital were COVID. And if you remember, at that time, we didn't have any testing. The testing started off with you had to get the CDC's permission to run a COVID test. So it was, everybody was a PUI, a presumptive, and it was a very confusing time. But we got public health involved that week and sort of gave that information to them, and they began to put it together about 2 possible funerals and that's never been confirmed, but it sure, the evidence suggests that it was a perfect storm. Big, large funerals here in Southwest Georgia, with a lot of people visiting from out of town. And actually, that first patient that we knew was positive had been transferred back to Atlanta. They were visiting one of those funerals. And he was actually the first COVID patient to pass in the state of Georgia a few days after we transferred him back to a hospital in Atlanta. So March 24th came, and we were exhausted. We were again asking ourselves, why here? And of course we don't, that's not necessary. And it was March 24th when the New York Times article came out, and my CFO, who was sitting right next to me, texted me the article. It was about 9:30 at night, and Albany, Georgia was the 4th hottest hotspot in the world, behind Wuhan, China, Lombardy Province of Italy, and New York City. And there was a lot of chatter at that time about PPE and running out and conservation and what people were doing, and testing was a mess. But we were in survival mode, and we have Dr. Black is one of our emergency room physicians, a great doctor. And I remember he's talked about how when people first started coming in, he was looking at their symptoms, and he said, people kept saying, I can't taste or smell. And he was saying, well, yeah, but let's talk about your breathing, and let's talk about your fever. And of course, now we know taste and smell is a sign of being positive. So it's been a journey. We've had those 3 surges. For us, nothing has topped what happened in March and April. We saw more positivity, almost 40% positivity outpatient in our community. We hit a high of 185 patients in our hospitals, ventilator use, ICU use, and it was dramatic. But we saw a spike in the summer like most, and then this last one in December and in January, while more sustained. The interesting part was it was almost easier in March and April because we were one of the few going through it. And so we could pull just different resources, while not PPE, but people resources. While this last one, everybody was in the same bucket, and there are no people resources available, no ICU nurses. And so each phase, each surge that we've had has been a different challenge for sure.
What's been the effect on the community? Have you noticed, is there more mask wearing? Is there strong vaccination push there now, since you've gone through this horrible time?
Yeah. Well, I'd love to tell you that we figured it all out, and we've been wearing our masks 100%. And but people are tired. Dr. Harris talked about the fatigue, and Dr. Del Rio as well. I think we've done a pretty good job as a community. We have certainly felt as a healthcare system that we fought COVID together as a community. I mean, we had people dropping off meals and cookies. I mean, I came in on Easter Sunday a year ago, and somebody brought by 1,500 cupcakes to hand out. And we're, on a Sunday trying to figure out how we were going to dispense 1,500 cupcakes. But the community really surrounded us with love. So we've always felt like we've been in it together. And I think that speaks to it now. I think mask wearing has been what we've seen here in Southwest Georgia, a bit politicized. And, if you knew somebody that had COVID or died of COVID, and that tended to be our underserved and our African-American and communities, there was great mask wearing. And if you didn't know someone or weren't affected, it tended to be more of a, is this really happening? And is it really that serious? And the numbers are inflated. So I think even now with the vaccine, where we've been working hard to vaccinate more than 33,000 people here in Southwest Georgia. We're the third most vaccinated county in the state of Georgia right now. That didn't happen by accident. We worked hard to do that. But we've only, even for our own employees, we've only got about 55% that have taken the vaccine. We've seen the study with the military recently, about 50-50. Nurses, the Nurse Association came out and said it's about the same, teachers, about 50% of teachers are going to take the vaccine. And so we're seeing the same. It's certainly been better in the seniors, in those 65 and older. And we've seen, while not equal, of the about 18,000 seniors that we have 65 and older vaccinated, it's about 60-40 from a Caucasian to an African American. So while that number should be flipped, we're working hard with the Pastoral Alliance, churches, other churches, schools. We've gotten into neighborhoods. We're working with Emory right now to do a really quick, impactful study about whether it's vaccine hesitancy, or our CMO, Dr. Grant, talks about it as vaccine confidence and that confidence level in it. So I think we vaccinated those that were ready for it, and now we've got approximately half of the people that qualify for it that have some level of hesitancy or confidence issue, and those reasons are varied. And it's really going to take a lot of individual conversations to convert that hesitancy. So the work's not over, and it's been, again, we're 2 weeks short of a year. It has changed in almost every phase what we're doing, but we all believe that the vaccine is truly the path to getting free of this and not having surges anymore. Because I would tell you, the healthcare system, to Dr. Harris's point, I feel like it's teetering. I was meeting with the CEO the other day. We have 3 hospitals, and I was meeting with one of the CEOs, and we're hardened folks. She was on the verge of breaking down, and it's hard to push it away. We've seen things and experienced things, and I remember Dr. Harris said a few months back, when people ask you if you're okay, it's okay to say, no, I'm not. And I think we've got a lot of that. That wave is still to come, but we're working hard to learn and to be able to adequately address it.
Thank you, Scott. Dr. Curran, you've had a lot of experience at the CDC, and that agency, as well as the White House, has been under scrutiny in terms of its handling and messaging around COVID. Can you evaluate how the CDC has performed during this time?
Well, thanks, Andy. And I'd also like to thank the participants in this conference. We say that public health is all we do as a society to assure conditions of health. And the legal profession is right in the middle of that, with legislation, torts, advocacy, as we know. And of course, the media are extremely important for clear and consistent, informed messages. So thank you. I think, what Carlos said is pretty important for us to keep in mind of, and that is everybody unanticipated how bad this was going to be. A lot of us in public health and infectious disease have been talking about, a terrible influenza epidemic or something really bad, but we never thought it would be this bad. We never thought there would be a respiratory disease that would kill 500,000 Americans the first year, and probably many, many tens of thousands more through a neglect of healthcare and cardiac disease and cancer and other areas. We never thought it was going to be this bad. And the CDC was part of that. The first thing they did, I think, is they didn't anticipate just how bad this was going to be. And that led to, among other problems, their role in the slowdown of testing to begin with. Mr. Steiner pointed out that testing was almost impossible to get to. And the US, I think, maybe partly is CDC-philic and part of it is Anglophilic or whatever. Instead of just grabbing onto the tests that were being used in Europe and buying them up, we said we can do it ourselves. And that undoubtedly slowed down through the CDC and FDA the initial availability of tests. The other thing the CDC had trouble with is surveillance. In general, they're this agency which collects information from state and local health departments and then turns it around to the public. That was ceded to Johns Hopkins University. Getting information from the public health networks around the world, we learned about COVID every day from Johns Hopkins University. And that, to some extent, takes trust away from government. The third thing is one of communication. And this is an area where the response was politically messed with. Public health is always partisan. You've heard from all of the other panelists the difficulty in communicating with different populations who may or may not trust us. Now, they can be underrepresented minorities, they can be school teachers, they can be poultry workers, they can be doctors, whoever they are. It takes specialized communication and trusted communication. That means that you have to trust the government to begin with. So in a pandemic, it's always going to be political, but it should never, never, never be partisan. Who would ever think that Republicans don't believe in masks and Democrats don't? The Democrats do. That comes directly from the White House, and the miscommunication that came from the White House consistently picked up by Fox News. And a lot of that was the muzzling of CDC. Ironically, one of the first people in the country to recognize how bad this was going to be, Dr. Messonnier at CDC, was immediately removed from her position of influence and never heard of again. And that was done from the White House down. So public health should never be partisan. And you'll notice a difference now as you see CDC emerge from the shadows, where and we have a good leader, Dr. Rochelle Walensky. She's on TV every single day talking to us. That's important because we don't exactly know what's going to happen with COVID. We can't predict the future completely. So as Tony Fauci would say, we have to be ready for change. We have to be ready to keep on building on what we know and communicating it to the public, and it has to be trusted. So while CDC was putting out 3,300 recommendations before the election, they almost never had the voice themselves to even talk about them. You didn't see an array of CDC scientists getting up and explaining the work that they're doing, or the hundreds of articles in the MMWR that have been written that haven't been explained. The CDC first published the importance of asymptomatic transmission. So a lot of the things that we didn't think was going to be this bad, we also didn't think that asymptomatic transmission was going to be this bad, or pre-symptomatic transmission would be this bad. And so a lot of it was somewhat wishful thinking, and it was also the muzzling of the CDC. So I'm optimistic now that they'll be getting more of their attention. But also what happened was that even though CDC is the world's premier public health delivery agency, it's not good enough. And now we know that. It's in better shape relatively than state and local health departments. And I'm chair of the Board of Public Health in Georgia. State and local health departments have seen their budgets cut consistently over time. And they're just a fraction of what they were on a dollar for dollar basis 10 or 20 years ago. Now we see how that hurts us. Do we have the manpower to do what's needed in testing and vaccines? Can we attract the talented staff who come to work with terribly deflated salaries at state and local levels? Georgia's not different. Georgia's the same as everybody, but we've just neglected this overall over time. So we see these kind of weaknesses. And in general, epidemics show us the fault lines in our society. And we have many fault lines in the United States. I guess, first of all, we have a very much of a federal system. There are limits to what the federal government can do, and there are limits to how much the federal government wants to do, which is another issue. I mean, why don't we have a national mask mandate? Well, it's up to each state, and then maybe not each state, maybe each county. I mean, that's not very much of a message. Why don't we have certain rules for schools which are national? Well, it's up to each county, it's up to each state. How about national health insurance? How about when all these people get unemployed? Can everybody get equal access to the healthcare they need? The answer is no. And of course, underrepresented minorities suffer more than others because they're more likely to be uninsured. So we have a lot of fault lines in our society, and this has done this, but I'm optimistic. And the reason I'm optimistic is that our country has learned and is learning from the perils of this pandemic. 40% increase in applications to schools of public health, including ours. The New York Times say that epidemiologists will be the biggest growth area in the next decade for jobs. The state legislature in Georgia gave an increase in funding during a time with the severe budget problems in Georgia, first increase in funding in about 10 years to the state of Georgia. So I think we've learned our lesson, and we've learned a lot about what can be done with COVID, and the science has been amazing. But there's a long way to go.
Talk about vaccines for a minute. I know that there's news about Johnson & Johnson's vaccine today. It's proved efficacious according to an FDA review. Talk about, how we've developed the vaccine, but more importantly, why has there been, it seems like the rollout's been slow. I mean, it's hard to evaluate, I guess, and it's better than it was, but it seems like it's slower than we thought it was going to be.
Well, I think that, while COVID has been a lot worse than anybody predicted, the science and the development of vaccines are much better than anybody predicted. A lot of us have been working in public health for a long time, would have been very, very happy to know that we would have any vaccines at all in anybody's arm within a year of the discovery of the virus. So here we are a year later, and we haven't done enough, but we have immunized, we have delivered 65 million vaccines in the US. To put that in perspective, in 1976, I ran the swine flu campaign in Columbus, Ohio. You guys remember the swine flu campaign, or if you were around in 1976. And that year, there were 45 million Americans immunized. Now, put that in perspective of 65 million already in the last couple months. So in a sense, we're moving faster than you would have predicted, and the vaccine supply is faster. But the main problem we have now remains still a shortage of vaccines and a shortage of ability to deliver them. And while I'm concerned about vaccine hesitancy, I'm afraid that the hesitancy issue will be blamed on the people who don't get the vaccine. And I think that there has to be an equity of information delivered by trusted people to all the people who get it. If the nurses don't want to get it, get the nurse leaders together and have the nurses speak to it. Make sure we have access to vaccines and trusted people, talking to people in minority communities who are doing it. So we have to not blame it on the people themselves, but go after it. Now, what are the concerns? Well, I mean, it's amazing that these vaccines have been so efficacious and that we can actually debate between whether 80% or 94% is much different. I think, in a trial, it's going to be different than the real world. There's a lot of things to worry about. We have the new variants that may or may not be totally protected. And of course, the new variants are not the only variants. They're the only ones that have been discovered thus far, as the California variant has shown us in recent weeks. So we can assume that the virus will continue to mutate, and it'll be a race with the vaccines. There's a lot of things we don't know about the vaccines. How long will they be effective? Do they prevent infection instead of disease? It looks like that's true, or at least they diminish infection enough to make them less transmissible. So we have a lot of optimism there, but can't be completely certain of that. The other thing, and the last thing I'd like to really say about this, is the issue of the global pandemic. One thing we've learned is that this can go from China to Albany fast. And that means that it will do that in the future. And it also means that these variants are going to keep on popping up until we have a global solution. So this is a solution that has to be attacking COVID everywhere in the world. And that's attacked by a couple of ways. One is there has to be adequate surveillance and tracking for these new variants and new viruses. And then there has to be partnership between countries who are not always friendly with each other on all terms. And thirdly, there needs to be adequate resources to get these things done quickly. So this is a global pandemic. We can't isolate ourselves from the future, and we have to attack it globally.
Thank you, Dr. Curran. Schmidtke, you've done a lot of great tracking of the data here in Georgia and the United States. And one thing you focused on recently has been schools. As the CDC has published guidelines for reopening schools, how do you see that playing out here in Georgia?
Well, thank you very much for the invitation to be here. It's great to be with such illustrious panelists. I will just say that yes, the CDC recently came out with new guidance that has to do with safe school reopening. I think we've seen some data that show that safe school reopening is possible. And I think that a lot of us really want that to happen. But it requires a strong commitment to safety culture, both within the building in terms of meeting certain mitigation strategies, but a strong commitment to safety culture outside of the building in the larger community. So we need to be doing the work of bringing disease transmission down to a level that's manageable and sustainable for contact trace investigation and such, so that we're not creating an unsafe environment inside of the school. And so what we've seen is, of course, a lot of schools in Georgia have reopened even before this guidance came out. And what the guidance says is it gives us certain benchmarks for what is a disease transmission rate threshold, where if you're above this, then that sets a certain instructional model. If you are below this threshold, then that's a different instructional model and who can go to school. And it's not just case rates, but they also are looking at test positivity rates. So it's the two things. And so it's a little bit confusing because if you're high for one metric and low for the other, you're supposed to go with the higher of the two. And when I did the analysis on Sunday, there were only 5 counties in Georgia that met the threshold right now for a safe school reopening. And they were all clustered in the southwest corner of the state. And so what this means, because like I mentioned earlier, there are a lot of schools that went ahead and reopened before the guidance, it's a reminder that, just because something is open does not necessarily mean that it's safe. And we have great examples of school districts throughout the state that aren't necessarily following the safety recommendations when it comes to masking, universal mask wear and wearing it appropriately, social distancing, and some of the other mitigation strategies. So it is a risk. And that's why I think the news that, Governor Kemp is considering adding teachers to the priority list for vaccinations is really exciting. I hope that will be an important step forward in this conversation about, bringing kids back into the school environment. I know as a parent, I very much want my children back in the in-person learning environment, but, we have underlying conditions. And so that is a sort of a tug of war that my family's experiencing, but many families across Georgia and across the country are as well.
What trends, Amber, are you seeing that are standing out to you as you track this disease progress here in Georgia and in the United States for that matter?
Well, I think that, obviously everybody can see in the data that cases have come down tremendously since the winter surge peak, but we haven't seen hospitalizations decrease at the same rate. And deaths, unfortunately, remain very high. They're a lagging indicator, but they still haven't started to trend down in a big way yet. What I'm a little nervous about is, as I'm looking at the hospitalization numbers and the patient census, so how many COVID-19 patients make up the entire hospitalized population for different hospital regions, is we're seeing multiple areas where hospital regions are starting to slow their descent. from that winter surge. And so what I worry about is, are we bottoming out? And if we are still at a high rate compared to how we entered the winter surge. And with the arrival of the new variant, is this a sign of a transition point? It's a little early yet to know for sure one way or the other. In public health, a lot of the times we recognize what's happening as we look back as compared to what's going on at the moment or going forward. And so, in a week's time, we could find out that this is just a momentary pause before a continued decrease. But it's something that's what keeps me up at night right now is looking at those hospital numbers.
All right, thank you, Amber. And what I'm going to do now is pose a question to the entire panel, or more than one question, because I'm a reporter, I ask a lot of questions. And if you feel like, jump right in terms of, if this is something that speaks to you. But what Amber just said is interesting in the sense that we're seeing case numbers go down here and nationally. And we're seeing vaccinations going up here and nationally. So is this the beginning of the gradually getting this disease under control? Or is it too early to tell?
Andy, I think it's too early to tell. I agree. I think the data looks good, but let's not forget that today, with 55,000 or so cases, we are really at the peak we were in the last summer. I mean, it's coming down, but we're still at a very high level. In most counties in the US, as Amber said, we're still in the red. We still have very high levels of transmission. We need to get those counties down to less than 10, ideally 5 or so, less than 5 cases per 100,000 population. Most counties right now are way above that. They're 25, 30, 100 per 100,000 population. We have to bring transmission down. My concern, as Amber said, is that hospitalizations, again, we've come down from 120,000 people in the hospital with COVID to about 65 to 70,000 people with COVID in the hospital. That's still a lot of people with COVID in the hospital. That's really, they come down from 4,000 to about 1,500 to 2,000 a day. That's still a lot of people dying of COVID. So I want to tell people we're coming down from Everest, and we just made it down to the first, place where you stop. We still have a long way down. There's still a lot of danger coming down. So I think we just need to continue have people, be careful, take care of themselves, mitigation, and yes, get vaccines. But the problem is there are not enough vaccines out there. And again, people are focusing so much on hesitancy, and I couldn't agree more with Dr. Harris. A lot of people that I talk to, they're not hesitant, they just are slow yeses. They have questions. And I think we need to use this opportunity to answer questions and to have a dialogue with people. A colleague of mine, Dr. Manning, said to me the other day, a visual that I really like, is we are dealing with people who are afraid of heights, and we need them to jump from the height, platform into the pool. And we finally get them up to the edge of the platform, and then we say, now you got to wait here because we still need water in the pool. You can't jump yet. It's not the right thing. We need to wait until there's water in the pool, and this is the right time to have that conversation, to talk to people, to tell them about vaccines. And when we have vaccines available, they'll be ready to get their vaccine appointment. There's nothing more frustrating than talking to somebody who's now ready to say, okay, I want to get vaccinated. And you say, oh, but there are no vaccines for you. That's really, it almost feels like the Charlie Brown Lucy thing of, pulling the ball at the last minute, right? We have to take our time. But as the government is getting more vaccines out there, we have to get those vaccines into arms. And I think at the US, we're doing actually pretty good. We would like to do better, but 1.4 million doses a day is not bad. And I think we just need to be a little patient. And that's one thing that I think it's in short supply right now, which is patience.
Andy, I think I 100% agree with Carlos, but I think that the fact that the cases are going down, fairly fast, they're still at a high level, but it also is encouraging to us that some of the things that we're doing might work and therefore need to be continued, including a couple things. One is vaccines, and then the fact that there probably been about 90 million Americans at least already infected who have some immunity. Now, not as good as vaccines probably, but some immunity. And that means if we really push and we can vaccinate more people, it'll help. Now, hospitalizations and deaths have gone down more slowly than cases. And the reason for that is a couple. One is that the elderly, people over 65, are about 80% of the hospitalizations and deaths. And that explains why Governor Kemp and other people have named them a priority. You know, by changing priorities and adding groups, that doesn't get Georgia more vaccines. You know, in DeKalb County and Fulton County, for example, there are thousands of people on waiting lists who are over 65 or are essential workers. And if you added all the teachers and all the staff and all the schools, you still have the same number of vaccines, just more people on the waiting list. And the reason people go with people over 65 is to stop the crowding in hospitals and stop the deaths and stop the misery. Now, sometimes the younger people, though, are bigger transmitters, and not necessarily just school teachers, but students themselves, young people. They're more likely to transmit, less likely to get sick. So what we have to do is get rid of the scarcity issue, make sure we have enough people who can do all the testing and all the vaccines when we finally get them. And I think we're going to get more and more. And then once, you know, half the country gets immunized, it becomes sort of the normal thing to do. And a lot of the hesitancy goes away when everybody says to their neighbor, haven't you gotten the shot yet? Or people are saying, well, you know, if you're going to come to school and you're not tested, you have to get a COVID test every other day. But if you're vaccinated, maybe you don't. Or if you want to go to work at your local law firm and you want to be in the same room as the other lawyers, you better be vaccinated. And then people are going to start to learn about it. And I think the hesitancy will go away if we provide the access and the equity of information.
You know, Andy, I'll just add one thing. Lots of lessons learned from this virus, but one clear lesson is humility, hopefully. And, you know, and so we should absolutely, I agree with Carlos that we certainly cannot declare victory. These numbers are going down. And that's what we should say today. The numbers are down today, but we don't know if they're going to continue to go down tomorrow. And so we have to remain vigilant. And yes, there is fatigue all around, but vigilant and make sure that we remember that this virus is very wily. And when we think we have something licked about this virus, it teaches us something new the next day.
One thing we've all talked about, all you panelists have talked about is hospitalizations. Let's talk about the impact on the healthcare workforce. Scott, you mentioned the impact there at Phoebe. I mean, this has been 12 months of intense energy and work by nurses and doctors and all sorts of medical professionals. What's been the impact and how can we basically give them relief? Or are we still looking at more time, more overtime, more staff burnout?
Yeah. You know, thanks for that, Andy. I sure wish I had all those answers. And, you know, we also quickly realized cupcakes no longer filled that need. And we've got a lot of very tired people. They're physically tired, but that doesn't hold a candle to their emotional and mental state. You know, as a leader, it's my responsibility. I was coming back from Atlanta today, talking to some folks about that, and you know, trying to really understand and leaning on our mental health professionals to develop that plan, and because that is coming. It's already here, but it's going to come in different waves, and because everybody handles and deals with this stress and this exhaustion, physical, mental, emotional, differently, and we're starting to see that evolve, as I mentioned about one of my leaders here, and you know, I'll be honest, I was unprepared to deal with that, and I need to, you know, other than saying, why don't you take some time off? Why don't, you know, that we're still working on those answers. I think that's probably most concerning, and that's everywhere. That's, you know, not in Southwest Georgia. The healthcare system is just flat out exhausted, and I think that what you're starting to see, especially in this last surge, was some of that frustration to, you know, seeing some of the postings of, can't you just wear a mask, right? Even if you don't think it works, can't you just do it for me? And I think we're seeing that a bit with vaccines. And we're all frustrated that we just hardly can believe everybody won't take it. But again, we've got to back it up, and we got to understand everybody's got a different reason. And this is if COVID went away in 4 months, we've got a decade of COVID to still deal with, I think, emotionally and mentally.
Let me just add to that, Andy. I agree 100% with Scott. I think there's two other issues that I see putting healthcare workers under stress. In this last peak, hospitals were really up to their limits. And what you end up having is your staff to patient ratio gets bad, and people start making mistakes, and people start not providing the kind of care you like to provide. And there's nothing more frustrating as a physician, as a nurse, as a healthcare provider, when you know you could be doing a much better job and you're not being able to do it because you are tired, you're overwhelmed, you're overstretched. That also creates incredible amount of frustration and burnout. So I think we need to also realize that part of it is just, you're a pilot that has been flying way too many hours, and you're going to make mistakes, and you don't want to, and that creates, at some point in time, people are going to say, I'll find something else to do. So we need to be really clear about that and the consequence that may have on our ability to recruit and retain the kind of people we want to have in healthcare. I do think that people like Scott and other leaders that have been visible, that have been in the front lines, that have made themselves available. Sometimes here at Grady Hospital, I pretty much every day I'm rounding on the floors. I go to the COVID units. I talk to people. People want to talk. They want to debrief. They want to tell you what's going on. They want to hear their frustrations. At the beginning of this pandemic, my biggest fear, people wanted PPE. We were having trouble with PPE. I told all the providers, look, we're going to make sure that no matter what, at whatever time you need something, it'll be available to you. If you need a mask, if you need goggles, we'll make it available. And I think having weekly to bi-weekly town hall meetings and having those communications have been totally critical. So communicating transparently with truth and listening to people, I think it's a very important thing that we as leaders have to do in order to keep people safe and healthy during this time. But everybody's stressed. And as Scott said, it's okay to say, I'm not doing well.
Yeah, I do want to say, certainly we have great leaders on this call. That was not a universal experience. And so I would just want to elevate that because, at the beginning of this, you even had some nurses and some physicians who were just speaking out about not having PPE and not having resources, and they ended up being fired or punished. So again, leadership does matter on this call. You had leaders who did not do that, but unfortunately, when I looked at the national landscape of physicians, that was a common experience. And I also, want to say it's very important, as Carlos said, and as Scott did, to routinize this care, because listen, and I can speak more for physicians than nurses, but physicians, always are willing to help others. We don't always do such a good job of helping ourselves. In some ways, over the many years, although this is changing, physicians are sometimes even disincentivized to ask for help, right? And by the way, I'm not talking about physicians who have, abdicated their, moral, but I'm just an ethical responsibility. And I'm talking about that, who are dangerous, but I'm talking about those who just need help. And, I remember when I first came to Emory, of course, I came in 1992. And the first year that I applied for my license, there was a question on the exam. Now, this has long changed, but there used to be a question that said, have you ever been treated for a mental disorder? Well, of course, that would then cascade into a lot of issues. And the right question, and yes, this has changed now, Georgia and really most other states across the country, has your ability to care for patients been impaired? That's what we, really want to get at. So certainly leadership does matter. It's system solutions. It's not doctors and nurses. Get extra sleep and eat your vegetables and, meditate. It's what system solutions. And of course, on this call, you see folks who are leading in that, but that's not always universally the case.
Thank you. Dr. Curran?
I think the healthcare workers are truly the heroes of this pandemic. And I've watched Carlos communicating with the Grady staff very consistently with weekly seminars and other things. There's another side to this issue of people who are suffering, and that's people with patients without COVID. Dr. Harris has already mentioned that the suicide rate's up. I'm not exactly sure why, but also opioid overdose rates are up after they've been going down for a few years in a row. Cardiac deaths are up. Many other types of deaths are up. And we're going to see that this is going to get worse because people don't have access to the health services they had. Not only from lack of health insurance, but simply lack of access. Kaiser Permanente, for example, in California has fully insured population, but they've seen an 85% decline in pap smears this year. Other places have reported great declines in mammography. My next door neighbor, this is an anecdote, is a cancer surgeon at Emory, and he says he's already seeing people with more advanced cancer coming in who could have been treated more easily and more successfully had they come in earlier. So we're seeing really big gaps in the healthcare system, which is being caused by COVID. And the decline in, this is a terrible decline in mortality in the United States. When people say there are 500,000 deaths, we usually have about 2.7 million deaths in the United States every year. Adding another 500,000 to that is a 25% increase. And that doesn't include the extra deaths from other conditions that could have been prevented. So this is a very widespread epidemic. And the doctors caring for people with these conditions, even if they're not working on COVID, are frustrated when they see their patients come in too late.
I had another question before we go to Hank, and that is, Dr. Fauci said it's likely that we'll be wearing masks through this year. Is that something that you can see occurring, or is there going to be a time when, people who have fully vaccinated will go without masks?
I think, Andy, that it depends what you're planning on doing, right? I think that, in general, I think masks, at least I think of myself in healthcare, masks are going to become like gloves. When I was an intern in the early 80s and I learned how to draw blood, we weren't using gloves. It was not, but then HIV appeared and all of a sudden we had universal precautions and now nobody would dare, get blood from a patient without using gloves. I think seeing a patient without mask is going to become something we don't do anymore. I think in healthcare, we're going to be wearing masks because there's going to be risk of this or other infections. And in a way, we kind of already doing it for influenza, so now we're going to do it more routinely. The reality is if there's certain activities, there's certain things, maybe going on a plane, you'll be wearing masks for quite some time. This is a global pandemic. Until this disease is not eradicated globally, there still is a risk. Dr. Curran said it well. A case in Wuhan means there's a problem in Albany. And I think we need to be aware of that. So just, in this globalized world, we cannot act locally. And, we have travelers, we have people from all over the world. We live in this global village. And I think masks are going to be with us for quite some time. It's going to be part of our sort of our dress. And, many fashion designers, Ken Cole and many others are making masks already because it's becoming a fashion statement too.
Andy, there's a couple of other things too. One is that, Tony also said that when he and his wife who've received the vaccine and all of their kids have received the vaccine, he would feel comfortable then all having dinner together without masks. So that fits into what Carlos is saying. It depends on what you want to do. I think if the vaccines work as well and continue to work as well as we think, there will be a lot of peer group pressure for groups to be vaccinated. I know certainly my wife and I are old and we got the vaccine. We aren't having our kids and grandchildren over all the time for dinner. And if they want to come, they better get the vaccine. And I think you're going to see that throughout the country. The other thing for Tony is that, for anybody right now to say that you can give up on the vaccine when the cases are going down, that's a mixed message. It's sort of say, well, if we can do it in September, why not today? So I think that, the overall message is we got to keep our foot on the gas, keep using masks, keep social distancing, stay away from congregate settings. We need to do more instead of less. And we don't want to say, well, if you wait a couple months, you're okay, because we don't know.
You know, Andy, on a slightly lighter note, and of course, as we evolve, I think there will be some cultural changes. But I remember several years ago, I think when I was a health director at Fulton, and we were having a particularly bad flu season, I remember thinking we should really stop shaking hands. And I socialized that with a couple of people, and they're like, oh, it seems so rude for us not to shake hands. And I was like, so I didn't say it, but I think we will no longer shake hands. I think the elbow bump, or, you know, maybe even the fist bump, but I think there are some new social norms that that will come out of this that actually keeps us all healthier.
Hank, if you're there, Hank Klibanoff, do you have any reader questions that have come forward?
I have some questions. Yes, thank you. First of all, this has been a terrific discussion. I think you may not know it because y'all talk about this all the time, but it's impossible to hear you talk and not come away both feeling inspired and empowered. It's even in the face of the reality and sometimes the stark reality that you paint, I think we who are not involved in it every day do come away from this feeling empowered. So thank you for that. We have a couple of questions, and even though I see some of you have answered, thank you. I'm going to go through them anyway because not everybody has followed the Q&A there. One is addressed to Dr. Del Rio, but frankly, anyone who wants to weigh in is fine. Dr. Harris raised the question of equitable versus equal distribution of vaccine. A noble idea, of course, but one that naturally comes with rules, regulations, and standards of enforcement that could possibly slow the effort. Connecticut's governor just announced a new policy based on the keep it simple, stupid approach, implementing a purely age-based system for eligibility, 75 and up, 65 and up, 55 and up, 45 and up, etc. Which is the better and speedier path towards achieving the best healthcare outcomes for the entire population? Dr. Del Rio.
So I tend to say that, you know, it may be complicated, but I really tend to focus on two things. What the vaccines we want them to do right now is prevent death and prevent hospitalizations. And we have to realize that 85% of the deaths are people over 65. So vaccinating those at higher risk of hospitalization and dying has to be the #1 priority. Once we get all those people vaccinated, then is when the issue starts. Who's next, right? Who comes next? And when you have a limited supply of vaccines, I think we really have to focus on equity. I mean, I really worry that we're not vaccinating the most impacted. I mean, African Americans died at 5 times the rate of white Americans, Hispanics at 3 times the rate. We cannot continue having that. So we got to get the vaccines to the people that need it the most. I would say that, you know, maybe we should have really said, you know, we're going to go to the inner city and vaccinate people there before we go to Buckhead and other places to vaccinate. I really think that we need to ensure how do we get more equity into our vaccine distribution. Once we have more vaccines, then you can do a lot of things. If the vaccines truly prevent transmission, and I think having Friday when the FERPAC meets, and if the FDA does approve this one vaccine of 1 dose, is going to be a game changer. Because we only then have 1 dose vaccine. It would be a big difference once we get that vaccine. But if the vaccine prevents transmission, I would probably go, the next group I would vaccinate are people between the age of 20 and 49, because those are the people that actually are sustaining the transmission right now. So if you have a vaccine that prevents transmission, after the people 65 and older, I would go to those individuals, because those are the ones that actually are, because you want to stop transmission, but we don't know if the vaccine stops transmission. And that's when you start getting all these different ways of doing it. What we need to do it is we need to do it as fast as we can. And what I hear and what worries me is when vaccine is being wasted, when there's places that have, you know, the other day, one of the mass vaccination sites had vaccine appointments for 3,000 people, and there were 400 people online. That's when we have to say, okay, if we're not targeting the people we need to, who do we get next? How do we get more vaccine? But we cannot waste time, and that has to be, so it's that very difficult dance. And I believe me, I don't envy Dr. Toomey or the people that are doing this, because there's no way to do it and satisfy everybody.
Is there any chance, though, that picking the 20 to 49 cohort in effect could be seen as rewarding those who have been the most disdainful of social distancing and masks, or does the data not support that? Maybe Amber, you might know that better than, or whoever can take that.
Sure. So I think we've seen a lot of disdain for the public health guidance across the age spectrum. I think you could argue there are just as many baby boomers who didn't care for social distancing and masking because of political reasons or other. But the data do show us very clearly that the 18 to 49 year group, and especially the 18 to 39 group, is our primary driver of cases. And so, as Carlos mentions, if you can limit cases, then you also limit the downstream effects too. You limit hospitalizations as well as deaths. So right now, obviously, the key is to bring down deaths and bring down the burden on hospitals as much as we can. But with the variant being out there right now, knowing that that's there and it's 40 to 80% more transmissible, having the same population of people that have been ignoring the public health guidance this whole time, now their risk of spreading it has gone up in a big way. And so that's why this really is sort of a race against time to try to get down into some of those younger populations and vaccinate them so that, they're not inadvertently spreading the disease, whether they realize it or not.
Mm-hmm. Yes, yes, Dr. Steiner.
Thank you. I don't disagree with that. What we have found, at least early on, is the most hesitant for the vaccine is that same age group, is those 18 to 39. So I think the thought that somehow they're young and they're going to know what to do, especially our females, they're very worried about what it might do from a reproductivity standpoint. And again, really no data there, but they've got it in their minds. And I'll tell you the unit we in our hospital have the most challenge with is our mother baby unit, which tend to be a lot of young women. And our percentage there is less than 20%. So I think that's the challenge. If we open it up to 18 to 49, you're going to disenfranchise the 49 to 65. But yeah, I bet you we would struggle to get 30 to 40% of that younger group to vaccinate, at least initially. Again, that conversation has to continue. But we were surprised to see that hesitancy among that age group.
And I'll just add that I think that, it's concerning that we haven't seen a strong education or science communication effort coming from the federal government or the state level when it comes to the vaccines to address a lot of these concerns that Scott is mentioning, because the time to have those conversations is now, like Carlos was saying, not when they're up on the high dive and thinking about jumping in the water. Like we need to lay the groundwork for that now so that they're ready when it's their turn. But I don't disagree with you, Scott.
Yes, Dean Curran.
Hank, what we have to realize, we're living in a very artificial environment, and priority setting is a means of discrimination. And you can discriminate in a lot of different ways. Why were all the healthcare workers first? Well, there's a reason for that. Why are the elderly first? There's a reason for that. But the thing is, it stops us from dealing with things like vaccine hesitancy and information campaigns, because we don't have enough energy to even get the vaccines out. Let's say there was no vaccine, no vaccine availability issue, which I think will happen, fairly soon. Then there would be nobody on waiting lists, and then we could go after the people that aren't getting vaccinated better. And also, there'd be a lot more peer pressure and peer influence to get vaccinated. When people started to see that the people who get vaccinated didn't get sick, and the other people did get sick, motivating. But right now, we live in this artificial environment of vaccine scarcity. If all of a sudden there was no vaccine scarcity, then we could deal with a lot of these other issues about the underserved or the underinformed or the people who don't believe in it. When you think about it, how silly is it that we have healthcare systems where half the healthcare workers haven't been vaccinated? And why aren't we dealing with it? Well, it's because we got other things to do. We got to take care of the sick people. We got to give vaccines to our patients. But if we had all the vaccine we needed, we'd send somebody to every single person and talk to them about vaccines. And I think it's very likely that vaccines will be close to mandatory in the healthcare system in the future if they continue to work. Most healthcare systems mandate flu vaccine, and flu vaccine is one of the crummiest vaccines known to man. But we mandate that. But we haven't gotten around to even those discussions because of vaccine scarcity. So this is an artificial world which will disappear pretty soon, I think.
So you think that the lack of a mandate is due to lack of confidence in the efficacy of the
Well, with
the
lack of a mandate,
vaccine?
there are no licensed vaccines. It's under a, it's under a federal emergency response. So you can't really,
Oh, right.
it's not licensed. And people are starting, different workplaces are starting to talk about requirements. At Emory, our students, for example, if they get positive, they get isolated and quarantined. Okay, well, if they're vaccinated, that's not as likely to happen to them. Being quarantined and isolated in a hotel is a very unpleasant situation. When people start to realize there's a benefit to be vaccinated, they'll want to do it. I think we're going to have, we could well have passports that have vaccines on. So if you get vaccinated, save your passport. And maybe you'll be able to get on an airplane if you haven't been vaccinated. I mean, I don't know, but we don't even talk about any of these things. They sound discriminatory, Dr. Harris, I know, but we can't even talk about any of them because there's such a waiting list to get in. Demand greatly exceeds supply. And once we have supply exceeding demand, then we can deal with the hard issues.
I'd say we have to talk about them because I think that's where we are. That's why we are where we are today regarding health inequities. And that's what we're doing right now. So we might not always agree, but I think we do have to be intentional and have the conversations. And, heretofore, we've not even had the conversations and elevated the issue. So, talking about something, elevating it, we might not get to a resolution. But again, we won't address issues of health inequities unless we are intentional. We can't, one of the sayings I hate is a rising tide lifts all boats. That may be true. But if, you are in a yacht, you're going to be impacted a little less than if you are in a canoe in that rising tide. So these are conversations we have to have, and we have to be intentional about these conversations. And Hank, while I just don't want to interrupt, but I do. The next question is about municipalities. So
Yes.
I'll start it and then have others. And I think one of the reasons I'm going to start this is because I am originally from West Virginia, and oftentimes West Virginia is the last, in every category, but certainly West Virginia. And of course, I know Clay Marsh and some of the folks in West Virginia, the medical school, who have been instrumental in the West Virginia response. But, West Virginia made a different decision, and I think there was an appropriate decision. They made a decision based on, West Virginia, right? And I think that's appropriate too. And so they decided to design their own system. And as you've seen in news stories, they've been pretty successful. And they use pharmacies and trusted, institutions in communities. And so I probably would not, though this question is asking about municipalities, which is setting up a whole other system. So before I got to municipalities, I would get to doctors' offices, because patients trust their doctors. And so I think the next phase before we get to setting up whole new systems for municipalities is to get these in doctors' offices. And of course, if this new vaccine is authorized that doesn't have the cold storage requirement and the one dose, certainly that will go a long way in physician offices having these and being able to get these in the arms of their patients.
And Dr. Steiner, you had some thoughts on this question also of municipalities setting up their own vaccination programs.
Yeah, and I really was thinking of it, and I'm not a doctor, by the way, but appreciate it.
Sorry.
But a lot of times public health, and we certainly know this in more rural or small urban areas, they don't have the resources to say, let's start doing a 500 a day or a 200 a day. And what we've found is for us in Southwest Georgia, we're absolutely willing to do this. I mean, and we went out and did it and in partnership with them, with our city, with our county, so we could do 1,000 a day. And we wanted to cut the flow of patients off coming to the emergency room and being admitted. So we had an absolutely interest in that. But I think you're going to find what Dr. Harris said is absolutely right. We need to get more and more trusted sites, pharmacies, doctors' offices, the Publix here in town, you know, if they're only doing 100 a week, hey, that is 100 people a week that could avoid this terrible virus. So what we have found is the public health has wanted to do this, but has really lacked the resources, and we're here to supplement that.
Okay, good. We have one last question. Andy, can I squeeze in this last question? I think that
Go for it.
Dr. Del Rio has answered here. Can teachers and others in schools be mandated to have vaccines? I believe Dr. Del Rio, you have a response here.
I'm not a lawyer. You guys know this better than me, but Dr. Curran said it very well, is, you know, until there's a full FDA approval, you cannot mandate something that is under an emergency use authorization. So it will probably be mandated in the future, but it cannot be mandated right now.
Mm-hmm.
It could be strongly encouraged, and I think you will see. I mean, I can see countries like Israel saying, if you haven't been vaccinated, you can't come here. You know, I can see certain things like that happening, but they can say things like, you know, if you want to get on, you know, this Delta flight, you need to be vaccinated. But again, that's a company making a decision. That's a very different story than a mandate, right?
If there's a way to incentivize people in addition to mandating it, for example, we were talking about students on campus. You know, you may have your choice of getting vaccinated or getting nasal swabs twice a week. And that could happen in schools too. Anybody who works in a school, you know, might have to be swabbed twice a week, which is probably much less fun than the vaccine. So I think that, I don't know how this is going to work out, but it's going to become normative if these vaccines.
And it could be a employee benefits program would give you a break on your premium, which happens for people who don't smoke. They get lower healthcare premiums.
Right.
It's got to be free and available for everybody. We got to, you know, if we want to make sure there's equity, we have to make sure there's equity of access, you know, and some of that is where you deliver it. You know, maybe a lot of people can't drive to Mercedes-Benz Stadium, you know, so you have to go in their neighborhoods and you got to charge them nothing for it.
Andy, I think we've got our questions asked and answered, Counselor. So thank you all for that.
Yes, and this has been a great panel. You guys are all terrific. I'm glad that you're all connected to each other and to us here in Georgia. It's been a pleasure. I learned a lot, and I appreciate the opportunity.
Happy to be with you.
Thank you.
Thanks.
Thank you. Thank you all very much. And everyone, we look forward to a session tomorrow at 2 to talk about the legal challenges of reporting on the pandemic and other healthcare issues in general. And then at 3:30 tomorrow, we have Richard Griffith's session on elections, including his interview of Secretary of State Brad Raffensperger. Thank you all for being with us today, and we look forward to seeing you tomorrow.